Very good evening to one and all, those who have gathered here on yet another session in this series of lectures that are arranged by IPS West Zone Research Committee on topics pertaining to help the postgraduate students master the fundamentals of research and publication. All these lectures, they are arranged once per month, and the recording of these lectures, they are available in the IPS West Zone YouTube handle as well. So if someone is not able to catch it today, they can go back to YouTube and see the lectures, revise it from there. Today's session is on a very important topic of understanding the basics of research scales on rating scales used in research projects. For today's session, I would like to welcome our chairperson, Dr. Avinash D'Souza. Sir is consultant psychiatrist and founder of D'Souza Foundation in Mumbai, and sir is editor, Journal of IPS West Zone, Annals of Indian Psychiatry. I welcome you, sir, to please introduce our speaker for today and chair this session. Sir, the floor is yours.
Yeah. It's an absolute privilege to be the chair for this session because we have a very astute speaker, Professor Dr. Sandeep Grover, who's a professor of psychiatry at PGI Chandigarh. He has an vast area of interest, rather. He has a lot of publications, over 900 publications in various journals with multiple book chapters, and he's been an editor of many books. I think I have written a few chapters in some of those books, so I'm happy to be part of his work. He's received numerous awards. He's been awarded thrice by ICMR. I think one is a very important thing is he's listed in the top 2% researchers by Stanford University based on lifetime research output. And most importantly, he's written a book by IPS, which is a primer on research, publication, etc., etc. And it's, I think, come out with a second edition also. So we're very happy that sir is with us, and I think I won't take up much time. I will ask sir to begin his presentation, and we'll of course have questions in the end. So and we will take it further from there. So I think over to you, sir, and I don't keep the audience away from you.
Is my screen visible?
Yes.
Yeah. So I'd like to thank the IPS West Zone and the chairperson, Dr. Avinash, the president, Dr. Neena, for inviting me here. So in today's talk, this is basically a series of talks on rating scale which I have. This is one of those talks. So basically there are 3 parts of the talk. So I'll be presenting only one part of the talk here because of the time constraints. So today we are just going to understand, we all use so many rating scales, but what are these, and what sense does this make to all of us? Let's try to understand that. So when we try to understand rating scales, we need to understand that rating scales are core to any kind of quantitative studies in psychiatry. When I say quantitative studies, we need to understand that we do qualitative studies also, where you use certain questions, but the answers which a patient can give can vary upon what they want to answer. Whereas the rating scales will have fixed answer responses, and that is where we differ between quantitative studies and qualitative studies. So basically the rating scales aid in us in having a disciplined dialogue, that there's a questionnaire with which a person interacts, and then there are responses from which a person is supposed to choose. So if you try to understand psychiatry and equate with medicine, rating scales can be equated to the getting an investigations report as in other fields of medicine. For example, you get the hemoglobin levels done for the patient, and you say that his hemoglobin is 6 or 7, so he has this level of anemia. Similarly, if you use a rating scale for depression and if a person draws a certain score, you say that patient has mild, moderate, or severe depression. So that's how you can understand what is the importance of rating scales. So what are these rating measures? They have a precisely defined format that focuses on the conversation between the responders and the questionnaire on particular relevant area. So all the respondents are invited to communicate in a shared language of the specific option choices. When I say this, it's important to understand that when we interview a patient in our ward or in our outpatient, we may have our sets of questions and which may vary from one resident to the other or one consultant to the other. And the responses of the patients are also open-ended and they can respond to whatever they want to respond to the certain questions if you ask the same question to different patients. So that is where the qualitative studies will come. But when it comes to quantitative studies, the language of the questionnaire remains same. You cannot have the option of changing the language from patient to patient or from person to person. And the choices of responses are also given set of responses which the person has to choose one of them. So from that perspective, we need to understand that rating scales are usually the close-ended measures with more than one response option. And these are more or less equivalent of or a variant of an MCQ that a patient is given an MCQ and is supposed to choose one of them. And we seek respondents' feedback in a comparative form for a particular issue. For example, you are evaluating sadness or mood, you give them the 4 or 5 choices for sadness to pick up, and then they choose one of them that how severe is their sadness. So that is where they are asked to compare what they are feeling and they can give a response to that. And the rating scales help us to gather information on the qualitative and the quantitative attributes for a particular condition. When I say qualitative, you can give a score, but give a description of the so-called that score. I'll be discussing that in the later part of the presentation for better understanding. So what are the usefulness of rating scale? They improve the collection, synthesis, and reporting of information that you can collect large amount of information in a short span of time. They tend to provide complete coverage of the relevant issue. For example, you are or me are interviewing a patient. It will depend on how much in depth into evaluation of depression or psychosis we go in. But when we are using a rating scales, it is expected that you cover the patients with all the questions which are part of that rating scale so that the coverage is complete. And they can help in categorization and quantifying, as I gave you example of depression. So they can help you in deciding mild, moderate, severe depression and so on. And these are much more rapid kind of assessments which you can do for a specific construct. And you can easily drive a numerical score based on that. You can readily interpret the data. And the rating scales, depending on how they are designed, these can be completed by the patient, the clinician, or any one significant others like caregivers or others, regardless of the response format and the irrespective of the application. So this is how we need to understand when you're looking at the rating scales. And they also help in communication between one clinician to the other, helps in clinical decision making. For example, if a patient scores 40 on HDRS, you know that he has severe depression and you possibly would like to give him ECT. And they also can help in screening and monitoring a particular condition. And in that sense, they are also cost effective. In a short span of time, you can do a complete comprehensive assessment of a patient. So just to summarize, the advantages of rating scales, these are questions that are easy to understand and implement. They offer comparative analysis for the person who is completing that. And it is easy to create various kind of surveys or studies by using these rating scales so that you can evaluate a lot of people there. Then you can collect a lot of abundant amount of information and you can analyze that and determine how to do interpret their data and what is to be done. And they are often considered to be the standards, that they are standardized by the psychometric properties. So whatever findings are there, they are not the kind of thing which we say that you have done an interview and you have collected the data that has its own value. But when you're trying to communicate and you're thinking about something which has been standardized, a rating scale or an interview will be considered much better. So what are the different rating scales? How do we try to understand them? So we understand rating scales as different types or different categories. So what are the different types of rating scales? Let's try to understand. We have numerical rating scale, verbal rating scale, visual analog rating scale, or Likert scale, graphic rating scale, or the descriptive rating scale. This is very, very important when, for example, when we are trying to do a research, if you know all these scales and you try to find out a scale accordingly, or the scale which you are going to use, if you can make certain changes that you can make it more understandable for the patient, it will be better. Let's see how what does these different types mean. The numerical rating scales use numbers to identify the item in the scale. For example, if you are trying to identify, let's say, itching for a person, so you give them a rating of 0 to 10 and patient is asked to choose 1. So that will be understood as a numerical rating scale. So this differs from a visual analog scale, as we will understand later. And what are the verbal descriptive scale or the verbal rating scale? These are basically that you give certain statements which is commonly there, and based on reading the statement, the person determines where he or she fits in. Like the description can be no pain, mild pain, moderate pain, severe pain. So patient will judge his or her ability, the pain, and will choose one of the options. On the other hand, the visual analog scale, if you see that they allow the participant to select any value from the scale in between the two endpoints. If you compare this as a numerical scale and this is the visual analog scale. So if you try to understand what is the difference between the two, for example, here you have 10 choices and choose one. Here the choices can vary from, let's say, 100 to 1000, because person can choose 7.7, 7.8, 8.2, 8.1. So this is also known as a slider scale, and this gives much more flexibility to the person who is filling the scale to choose what he thinks is the best for him. Then comes the Likert scale. The Likert scales have certain assumptions. That is where you need to understand that whatever the options which are given, that is the strength or the intensity of the construct which you are measuring, is in the continuum. That is what is presumed there. That is where we need to keep that in mind. And most of the rating scales which we use in the clinical practice or the research practice are actual Likert scales. And for example, for the agreement, you can have variation from strongly agree to agree, undecided, disagree, strongly disagree. So this, if you look at that, these are 5 different constructs, but it is presumed that the strongly agree can be given a score of 5, agree can be given a score of 4, undecided can be given a score of 3, disagree can be given a score of 2, and strongly disagree can be given a score of 1, depending on the kind of construct which you are measuring. And so same applies true for others. Or the rating can also be 2, 1, 0, -1, -2. So depending on the construct which you are measuring, you can decide that. But it is presumed that the gap between these two options is almost equal. So this is where you need to understand that basic difference of Likert scale. And that is why when we are using the Likert scale, this can be understood both from a categorical variable or also a continuous variable. So we'll come to that understanding also slightly later. Then are the graphic rating scales. That here, instead of the numbers, you use pictures such as stars or smileys for the face for assessment. For example, if the scale has only these smileys and you are asked to rate the pain or your sadness, patient may choose one of them. So accordingly, you can understand the level of severity of depression. And as you see here, we can combine the numerical scale, the graphical scale, and the verbal scale together for a better understanding of the patient. For example, patient can choose either of these. And for example, patient has mild and he is confused between mild and moderate pain, but there's a in-between category which he also has an option to choose. So that is where the scale, when you're designing or when you're choosing, keep these things in mind, that what would be the best way that you can communicate the information to the patient. Then are the descriptive rating scales. Here, although we are using the numbers as 0, 1, 2, 3, 4, you can see that each option has a description or an explanation. So person has to go through this, or the person who is interviewing the patient will go through that particular description and try to fit the patient to the closest possible option which he or she thinks applies to the person who is being evaluated. And these descriptions can be in very comprehensive way. For example, these are the 2 items from HDRS, or all of you may be using PANS. So you would have seen that PANS for each item, the description from 1 to 7, there are different grades of description being given. Then what we need to understand that these types are not mutually exclusive, and many times you can combine different scales, and these can be combined together to use. I have already discussed this. So you can combine the different kind of graphics and other things for better understanding of the patient, and these all becomes important specifically when you are designing a scale. So if you look at here, you will see a lot of, there's a verbal description, there's a graphical description, there's a numerical description, and there's a description. So descriptive. So you are combining 4 of the things for person's better understanding. For example, person starts how he thinks his pain is mild, moderate, or severe. For example, he says maybe my pain is mild. Then he has 3 choices to choose again. So that is where you have to understand that what would be best fitting to your patient so that he understands what you're trying to look for. That is very, very important when you're looking for a scale. Now, moving from types to different categories of the scale. This is again very, very important to understand. So here, when we talk about the categories, here we need to understand the kind of data which is being generated. So the most of the data, the rating scale which will be generated is the quantitative kind of a variable, where each item which you have rated will be can be a continuous variable or can be a discrete variable, or there could be nominal variable or ordinal variable. I'll discuss this slightly. So let's try to understand from this perspective that rating scales can be divided into 4 categories, that is the nominal scale, ordinal scale, interval scale, or the ratio scale. Now, you need to understand that this is a hierarchy, that a ratio scale can behave like an interval scale, can behave like an ordinal scale, can behave like a nominal scale. So whenever you are trying to choose a scale, prefer to choose a ratio scale which can be converted to others. But if you start from the lower level, you cannot convert that to the higher level. So this is where we need to understand what are these 4 different categories of scale. So what is a nominal scale? For example, nominal scale is a naming scale where the variables are simply named as labels with no specific order. For example, what is the gender, male, female? There is no order here. What is your hair color? It can be a different color. So there is no order here. We are just labeling the category. So these are understood as the nominal scale. For example, when you try to evaluate a lot of socio-demographic variables, many of the variables there will be nominal scale variables. Then is the ordinal scale. Here again, there is a presumption that the choices which are given have an order without actually establishing the degree or variation between them. But it is presumed that there is an order between the different items, and most of these ordinal scales are Likert scales, and technically we also end up using them as continuous variables. So this is where you need to have that kind of understanding, that because there is a presumption, you can use this as a numerical score. Then are the interval scales. Again, very, very important here that interval scales they can offer labels, they can offer order as well as a specific interval between each of these options. And in the interval scale, there is an order which is classically defined, clearly known. For example, here we are using temperature, for example. So we know what is the difference between 70 and 71, which is an equal, actually meaningful difference we know. And there's a presence of a zero, which is an arbitrary kind of thing, but there is no true zero. Means, for example, when we are measuring temperature, a person can have temperature -6 also. So there is absolutely no true zero here. This is where you need to understand are the interval scales. Finally, coming to the ratio scale. These are considered to be the ultimate nirvana when it comes to the measurement of any kind of data, because it can accommodate zero also. And for example, here, that is where this is most meaningful, that these variables can be meaningfully added, subtracted, multiplied, divided, and so on. So when you are choosing a rating scale with the different options, try to look for the scales which have descriptions are more or less like a ratio scale. Let's try to understand how are these. The ratio variables, there will be no values less than 0. Like I said, in the temperature, you have -2, -6, but here you cannot have 0. For example, height cannot, or the weight cannot be less than 0. So it can vary from 0 to more than that. So there's an absolute 0. For example, if you look at this question, how much time do you spend daily watching television? Here, when we are looking at the categories, less than 2 hours, 2 to 4 hours, 4 to 5 hours, 5 to 6 hours, and more than 6 hours. There is no category called less than 0. It cannot be. You cannot have less than 0 value here. So similarly, when you're choosing the scales, look at the options of the given items so that you choose a scale which has a ratio, although there is some order to that, there is some interval to that, so that you can use that as a continuous variable to analyze your data. So that is something which we need to keep in mind when we are thinking about selection of the scale. So for example, just simply again trying to buttress the point, if you look at the nominal variables, there is no true zero, there is no equal interval, there is no order, they just have categories. When we talk about ordinal, they have an order and they have categories. And when it comes to interval, they are actually at a equal interval, and accordingly they have order and categories, where a ratio will have a true zero. And these include examples like age, height, weight. So why this is important to understand? This is something which we need to understand. So when you are trying to understand this, depending on the kind of rating items which you have chosen, you can decide what how can the data be analyzed, mean, mode, median, what can be determined from which scale. So if you have chosen a scale which has actually the ratio kind of things, that is the best scale, because you can, whatever you want to do mean value calculation, median, mode, or you want to understand the difference between the variables that can be evaluated. You want to do addition, subtraction, multiplication, division, everything is possible. So that is where you need to keep that in mind, either when you're designing or choosing a scale. So with this basic understanding about the rating scale, let's try to understand selection of the rating scale, because that is again very, very important. So for various constructs, multiple scales are available for assessment. For example, when you want to assess psychosis in a patient, you can have option of SAPS, SANS, PANS, and different other scales, whatever you want to. Similarly, for example, if you want to assess depression now, there are so many scales which are available for assessment of depression. So how do one choose one of these? This is something which we need to understand, that many times the students will go to the guide, or the students may choose something randomly on their own without understanding what would be the best scale for that particular purpose. So what are the factors which determine the selection of the scale? This is again very, very important, because tomorrow when you're thinking about publication and other things, a lot of things will come into place. So what is the purpose? Do you want to screen a particular group of patients for a particular disorder, or you want to make a diagnosis, or you want to assess the severity? So ideally, when you're looking at a scale, if it can give you all three, that it can be used for screening, it can be used for diagnosis and severity, that is the best scale. But usually you will have scales which have a combination of screening and severity. The diagnosis is usually based on the interview measures, or so-called diagnostic interview. So this is where you need to understand that. Then who is going to complete the scale? Is it the clinician? Is it the patient? Who is the caregiver? So that will determine what kind of scale you are going to choose. Because if for example, you want to use PHQ-9, which is available in the local language, patient can complete it. So it reduces the burden on the clinician. So that's how you have to understand what kind of scale you are choosing. For example, if you're choosing BDI, a patient may be able to complete, but HDRS is not usually recommended or not validated to be completed by a patient. That's where you need to understand. Then study group. For example, you want to assess depression in a patient coming to your OPD, or somebody who has a comorbid medical illness, which would be a better scale, HDRS or BDI or PHQ-9. So if you look at in medical ill, PHQ-9 and BDI are more valid scales, because they have less burden of the somatic symptoms per se, especially the BDI. So that would be a preferred scale. Then is the issue of copyright, or the scale is not copyrighted, because in today's world, there are a lot of issues with regard to the use of copyrighted scales, and some of these scales are paid. And that's why if you are using a copyrighted scales and tomorrow you are trying to publish, and it can lead to a problem to you because you have not sought the permission or something like that. So you have to be very, very careful. Similarly, whether the scale is available free or you have to pay for use it, and the age group which we are evaluating, children, adolescent, elderly, because these will have different scales for depression. If you look at that here, the scale for children is different, geriatric population is different, adolescent is different, and similarly for people with medical illnesses, you may be using hospital anxiety and depression scale, which is more valid. So you have to understand these nuances before you choose a particular scale. The other factors which you need to keep in mind are the psychometric properties, which includes the reliability, validity, the sensitivity, specificity, positive predictive value, negative predictive value, and the availability of the translated and adapted version, and whether these have been validated or not. So these are pure psychometric issues which we need to keep in mind when you're evaluating a scale. And similarly, when you're looking at the reliability, validity, and other psychometric properties, you also need to understand, have these been validated in kind of population which you are actually interested in evaluating? Have these been validated in your country or your cultural background? Because these will again determine, when you're trying to publish, you have done all your hard work and you send your paper for publication, you just get one comment that you have used a scale which has not been validated, so the findings are not valid otherwise. That's how a paper gets rejected. So let's try to understand the instrument again. We're trying to understand, well, if you want to choose between diagnostic versus a screening instrument. So the diagnostic instruments are those which provide definitive information about the presence or absence of a target disease or condition. For example, when you're using, let's say, Mini is considered to be a diagnostic interview, or SCID, it is considered to be a diagnostic interview. Whereas Screening tests these are less definitive. They compared to the diagnostic test, the sensitivity, specificity, especially the specificity may be low, and they are useful in larger group of patients. For example, when I say this, when you want to study, let's say, do an epidemiological study in the population, you want to evaluate a particular construct in a rapid manner, you can screen people by using a screening instrument, because that is less time consuming. So that's how you need to understand. So from here, you need to understand this, for example, who is going to use it, and that will determine which instrument may be valid, for example, diagnostic versus screening. For example, you want to assess depression in medically ill and you want to publish that data. If you are using a diagnostic interview, it may be still better rather than using a screening instrument. For example, you are thinking about using ICD-11 criteria, DSM-5 criteria, MINI, PHQ, BH, all this. You need to understand that tomorrow when you're trying to publish, it will be more valid considered if you have evaluated your patient by using MINI, because that is where the diagnosis is more definitive and more sure about that. That's why when the editors or the reviewers are looking at your paper or data or your study, they look at these aspects. And if you're methodologically you are flawed here, nobody can save you. Similarly, when a physician wants to evaluate a patient depression in medically ill, he is not qualified to maybe, or has not been well trained to use MINI, because you need some psychiatric level of training to use MINI. So there, for him, he may use PHQ-9 or BDI, but the quality of data or the definitiveness of the diagnosis will be poor. That is where we need to understand. That is where, if you are involved as a researcher with anybody, especially evaluating patients in medically ill, so there's another design which is being suggested as a two-stage screening. That initially you use a screening instrument like PHQ-9 or BDI, and those who screen positive are further evaluated by a psychiatrist or a mental health professional to confirm the diagnosis or refute the diagnosis. However, the major limitation here is that you're not assessing who have screened negative. So you could lose some of the people who actually screened negative, but could have been positive. Otherwise, it is still a middle path where you can evaluate large number of people by reducing the burden of assessment. Then we are trying to understand, when you are trying to understand screening instrument, there are certain things from a psychometric point of view which we need to evaluate is the understanding the sensitivity, specificity, positive predictive value, and the negative predictive value. So sensitivity is understood as the ability of the test to detect a disease, and the proportion of the disease that was correctly identified is sensitivity. So what percentage are true positive? So sensitivity is true positive divided by true positive by true positive plus false negative. Whereas specificity is ability to detect no disease. Although we talk about specific, means specific that they can clearly say that this person has no disease. That is where you need to understand the specificity. And again, it is understood as the true negative divided by true negative plus false positive. So this is where you need to understand when you're looking at a scale, and when you're looking at the different scales, you need to keep this in mind. And these screening instruments, they are not usually affected by the prevalence of the disease. And in order to increase the sensitivity of the test, it may become less specific. So you need to understand this, that where are you going to draw a boundary, and how we do that, we will understand that. So sensitivity and specificity will look at the presence or absence of a disease, and we need to balance these two. You just cannot rely on one thing. So the basic principle to remember when you are trying to understand sensitivity and specificity is the snout and the spin rule. Sensitive test rules out the disease, and specific test rules in the disease. This is where you need to keep in mind. Whereas the positive predictive value is understood, if you look at this figure again, is the proportion of the test results that are truly positive. So positive predictive values will determine whether this test should be used in clinical practice or not. So that is where you need to understand. Similarly, the negative predictive value is the proportion of the negative test results that are truly negative. So it will determine how much this test should be used in the clinical practice. So they take into consideration the prevalence of the disease, and the positive predictive value and the negative predictive value will look at this subject from the point of view of the test results being positive or negative, and it determines the likelihood of it being correct, so that this is clinically useful. So this is where you have to look at these 4 values when you're selecting a screening instrument. So in other words, these positive predictive value and negative predictive value will help you to understand that which test to be used and not to be used, so that it helps not to use different tests indiscriminately, basically. For example, when we are talking about the simplest example to understand that we are talking about vitamin D levels, 99% of the population is said to have vitamin D levels low. So with the current cutoff which is being used, is it sensitive, specific enough? Is it useful clinically? These are the questions which often people ask. So how do you balance the so-called sensitivity and the specificity of a given test when you're trying to develop or when you're trying to look at? There is something called as ROC curve, or the receiver operator characteristics, which is a graphical plot used to understand the diagnostic ability of a binary classifier. So when you look at the ROC curve, you need to look at this, that it draws sensitivity at one level is the y-axis and the specificity at the other level. So when you're trying to understand that, here, when you look at the leftmost part of the figure, higher the value, for example, here, if the scale ROC is here, it is 100%, here it is 75%, it is 50%, if you look at this whole square, and this is 0%. So higher the ROC of a particular scale, you will understand that it has a much better balance of sensitivity and the specificity. So as I said that sorry. So as I said that sensitivity is usually drawn in the y-axis and the specificity is drawn on the x-axis, and that is where, depending on the area covered, you will determine. And how we calculate this, as you put the sensitivity value here and the FPR here, that is 1 minus specificity, and then you determine the so-called ROC. So it is a trade-off between sensitivity and specificity, so that you produce a test result that is numerical on a numerical scale rather than the absolute positive or negative value. So for example, area under curve is 75%, 80%, 100%, that will determine. So if you have anything ROC is more than 75% is a good test, you need to understand that, and that is what you need to be choosing. So it basically draws the balance between the two. So you can compare two tests also by using the ROC and try to understand the sensitivity and the specificity of a particular instrument. And area under curve 0.5 means the test is no better than by chance, and 1 means the test has a perfect accuracy. Now, the different cutoffs for ROC are chosen, whether one wants to maximize the sensitivity or specificity of the test. The ideal cutoff is one which picks up a lot of disease which has high sensitivity but has very few false positive, also has high specificity. So this is where, when you see the different scales, when we look at their sensitivity and specificity, when they try to talk at that PHQ-9 at a cutoff score of 10 has specificity of 75 or 80% and sensitivity over 75 or 80%. That is the best trade-off which has been received for that particular scale at that score. If somebody changes the score from 10 to 11, the specificity may increase, but the sensitivity may reduce. Similarly, if you reduce the score to 9, the sensitivity may increase, but the specificity will reduce. So that is the balance we try to determine when you're trying to use so-called create the different cutoffs for different scales. Now let's try to understand the reliability and the validity of the different scales after understanding the sensitivity and specificity part of it, because these are other psychometric properties you should need to look for the different scales. So we have reliability, we understand from a rating scale at 3 types, that whether it is over time, across items, and across different researchers. So accordingly, we understand test-retest reliability, internal consistency, and the inter-rater reliability. So test-retest reliability is the over time, that it requires using the same scale in a group of people twice with a certain gap between the two assessments, depending on the kind of scales which you are using and the stability of the construct. And then you try to understand the correlation between the two assessments by using a Pearson correlation coefficient, and any test-retest correlation of more than 0.8 is considered to have good reliability for that particular scale. And if, for example, the different constructs which have been shown to have consistent over time and good test-retest reliability are intelligence, self-esteem, or the big 5 personality dimensions, these have been shown to have good test-retest reliability. When it comes to internal consistency, here again we need to understand is what we are trying to determine is the reliability across items. For example, you are trying to assess depression by using PHQ-9. So what is the level of correlation between the different items of PHQ-9 is what you will determine the internal consistency of a scale. So it is the people's response across the different items on multiple item measures. And in general, all the items on such a measure are supposed to reflect the same underlying construct. So the people's score on those items should correlate with each other. So this is where you need to understand this. And if this correlation is not there, they are not correlated, this will no longer make a sense that the scale is actually a valid scale. So internal consistency can be measured by evaluating the split up correlation. It involves splitting the different items into two sets, so that first set and the second set, and then trying to, in the form of either odd, even, random numbers and so on. And you try to, the computer or the software will try to compute the internal consistency by using the split up correlation. And again, 0.8 is considered to give a good indicator. So another indicator of internal consistency is the convex alpha. You need to understand that if your scale has 10 items, there are 252 ways of differently dividing the different items. So when you do run that computer test, it does that the same for these 10 items in 252 ways to determine the internal consistency, which may not be humanly possible for anybody of us to do. There's many calculations to determine. So understand that when somebody is doing that and there's a computer is giving you a result of internal consistency greater than 0.8, 252 times that items have been looked in different permutation combination to understand this. Then is the inter-rater reliability, which is evaluated for scale or instrument that involve significant judgment on the part of an observer or a rater. Here, there are two raters who are going to evaluate a person. So either you use a video or a patient is being interviewed by one or maybe both, and they are rating the patient simultaneously, but independently. They are not consulting each other. So that you can understand that when a patient is being seen by two people, are they both reaching to the same conclusion for the patient or not? And it is again evaluated by convex alpha, or if it is a categorical variable, you use the Cohen's kappa to understand that. Then trying to understand the validity. Validity again has to be understood from the content validity, the criterion validity, and the construct validity. We have different kind of things. So when you're looking at this validity, usually when we look at the different scales, we do not bother much about it. But these are things which again are very, very useful. So the phase validity is something which you need to understand, is the extent to which a measurement method appears on the face to measure a construct of interest. For example, if you want to measure depression, so that the scale has items for mood, or so-called sadness of mood, anhedonia, or you want to evaluate somebody has DART syndrome, whether it is evaluating the various components of DART or not, or at the face value, you can understand that by looking at the face value. So face value is usually not determined by various statistical methods, but it's a starting point where it can be just looked by certain researchers, and they can say whether it is actually measuring that or not. The next level of validity is the content validity. So again, if you look at the face validity, it says whether it is measuring that or not. Content is measuring whether it covers the construct of interest. There's a full coverage or not. So that is where you need to understand there is a slight difference between the content and the face validity. And it is assessed by carefully checking the measurement method against the conceptual definition of a particular construct. For example, you are to evaluate depression or something, you need to look for against that DSM-5 criteria to look at the good content validity for a particular scale or not, whether it is covering all the DSM-5 criteria or not. And how do we determine? For example, when the scale is made, the 4 or 5 experts may be given the scale to rate different aspects of the particular scale. It can include the objectives of the scale, format, font size, whether the meaning of the words is clear, instructions are clear, measurement is appropriate or not. And every expert, if they agree on all these responses, you can say that the content validity index of the scale is 100%. Whereas if they are not agreeing on certain things, like here 4 out of 5 are agreeing, the content validity is 0.6, because one is positive and one is negative, so only 3 are positive. And here again, similarly, if you look at the content validity is 0.2, and they could be -2. So this may help you in determining when you're looking for a particular scale, or you're designing a scale, that which items to be incorporated and which items to be deleted, or similar way, which items to be modified, reworded, or something to be done so that we improve the content validity of the scale. Then comes the criterion validity. Criterion validity is the extent to which the people's scores on a measure are correlated with other variables, which is known as the criteria that one would expect them to be correlated with. For example, when we are trying to evaluate quality of life, we are constructing a scale for quality of life, how it will correlate with, let's say, severity of depression. The common sense says that higher the severity of depression, poorer will be the quality of life. So this is how you are using two scales in the patient to assess the criterion validity. Suppose you are evaluating the scale for quality of life, and then you use depression rating as another measure to see whether the validity of the quality of life scale which you are designing or you are using is good or not. And similarly, the reverse may be also true. So, for example, when you are trying to again evaluate quality of life in patient with depression, again, if you are looking at the criterion validity, which is the second scale is a generic quality of life scale. You want to choose severity of depression, disability, dysfunction, anything can be chosen to understand the criterion validity. And criterion validity again can be understood from two perspectives. One is a concurrent validity. For example, when you are using quality of life and severity of depression, and there is something called convergent validity. When you are measuring the same construct by using two different scales, it will be understood as the convergent validity. When you are measuring two different constructs which are either running in the same direction or opposite direction, will be understood as the concurrent validity. Then there is something called predictive validity. It refers to the extent that it is valid to use a score on one scale to predict the value of some other variable. For example, longer the DUP, there will be poor outcome. You are measuring duration of illness, but you're predicting the outcome. Or, for example, if somebody is taking a pre-employment test, and then you think what would be his employees would be, how productive he will be, or by looking at the IQ of a person, you can say how much he may be earning. So these are certain variables which are understood as the predictive validity. And the other is the discriminant validity. When, as I said, that when you are using quality of life and the disability, so ideally these are overlapping concept at one level, but they are also different. So when you are using two scales, one is quality of life and the disability, technically how much is the overlap and how much not is the overlap will help you in understanding that how much discriminant these two scales are. The other kind of validities which needs to be understood are the conceptual validity, semantic validity, and the technical validity. The semantic validity basically is understood when you are trying to use a translated scale, that how much the scale is actually conveying the same meaning as which was there in the original scale. That is what you need to look at, the semantic validity. This is not again statistically evaluated, but you need to check the wording from word by word. And the conceptual validity is again measuring the same theoretical construct within each culture. So depression assessed by PHQ-9 in USA and depression assessed by PHQ-9 in India, are they same across the different cultures, is what we need to understand. And the technical validity is understood as the method where the assessment is comparable to each culture. That when you're using this is basically more valid when you're using a self-rated instrument. Whether it is affected by literacy or not is something which you need to understand. If it is affected by literacy, it is not technically a very valid scale. So for example, the simpler example here will be MOCA. It is said that when somebody is less literate, you add 1+ score there. But I don't know whether that adding 1+ score still overcomes the different cultural aspect or not. So this is where it may be having a compromise on the technical validity. So how do we end up selecting scale? We need to understand how frequently it has been used, what kind of population the instrument has been used earlier, has the instrument been translated or not, and has the instrument been adapted or not, and has the instrument has been validated in your culture or not. So these are the factors which we need to keep in mind when we are selecting the scales. I'll stop here. I'm not going to take into translation and adaptation, because this is another part of the whole presentation, so it will require another discussion. So I'll stop here and thank you for patient listening. Thank you.
Well, if there are any questions, I think we will take them. We have asked participants to put in their questions in the chat box, but If anyone would like to raise their hand and ask, also you're welcome. Anything that you want to ask? Yes, Pooja, please go ahead. Yeah.
Sir, can I ask, sir, there are certain scales that are available on the published paper. Like the paper itself, it has it on a table all the items because they have used it. So is it okay to use such scales from the paper and cite the paper, or we should actually ask for permission as well?
So you're muted. Huh?
Yeah, usually when the full scale is given in a paper, in the form of an appendix, it can be presumed that this is a free scale. But when it is not given as an appendix, you need to understand that you require permission. But ideally, although if at all it is given as an appendix, it is always good and important that you seek permission from the person who has developed the scale. Because then you are on the safer side, and always preserve that email for any future problems. So it is very, very important to do that.
Thank you, sir. Thank you for this.
Yeah. I know that this is a dry topic for people to understand, because many times we keep on using it, but we don't understand the basics of it. So it often appears as a dry topic to understand why it is important to understand so much. But if you don't understand this, you possibly end up using wrong scales in your studies, and that's where you have problems while publication.
If the scale is very expensive, like the scale, so is it even possible for us to obtain the purchase it?
See, if there is no option other than purchasing it, then you are left with other two options: either look for an alternative scale or purchase it. So it totally depends on how desperate you are to use that scale. So you need to keep these two factors into mind while determining that uh, whether it is good to purchase or not. Because, for example, today, if you want to publish a study, when you say that I have used Mini, I have used KID, or I have used only DSM-5 criteria, the editor and the reviewer may have different views about these three. If you say I've used only DSM or ICD-11 criteria, he will say that you have not used a structured instrument. But if you have chosen Mini or let's say SKID, it will have much better weightage.
So someone has asked, do we have to determine all reliability and validity indices for a new scale?
Technically, depending on what kind of scale you are developing. For example, if you're developing a diagnostic instrument, let's say you want to develop a depression scale, whether you can assess depression by using that or not, then you have to go through that sensitivity, specificity, ROC and other things, and positive predictive value, negative predictive value. But at least the sensitivity, specificity, you have to do it, and ROC you have to do it, and also do the inter-rater reliability test, retest, depending on who is going to complete the scale. So, and this much is important. You cannot do away with this. Now, the question comes in that if you are using already an available scale, there's an important thing here to understand. For example, you are using HDRS in your study, but it has not been validated in your population, but you're ending up using that. So it is always better that you at least evaluate the internal consistency of the data for which you have collected the study, use this study scale. For example, you have used HDRS in 100 patients, just run the internal consistency in your data. So if your internal consistency in your data is coming beyond 0.8, the editor and the reviewer may be happy. Okay, at least you have evaluated some part of the psychometry. Otherwise, the data is available with you. But we usually don't do that. We don't calculate the internal consistency. Nowadays, the editors have started recommending that if it has not been validated other aspects, at least internal consistency you can evaluate in your own data.
Well, I don't think we have any more questions left, sir. So I would thank you for, I think, an excellent presentation and for being here with us despite having a very hectic schedule. And I will now hand over to Pooja to close up and whatever formalities are there.
Right, sir. That's it. Before closing the session, I'd like to thank Dr. Sandeep Grover, sir, for the excellent session, and Dr. Avinash D'Souza for chairing the session. Then we can
Thank
thank
you.
you all the participants. We can close the
Thank
session.
you. Thank you.
Thank you.